Good evening, everyone, and welcome to tonight's primary care seminar hosted by the Primary Care Education Department at City St George's University. My name is Roa, and I'm a GP and clinical lecturer at City and St George's. As some of you may know, the seminar is part of, apologies. The seminar is part of the seminar series, which really was co-created with students, aiming to showcase the diverse opportunities available within a career in primary care. And our students are really at the engine and the driving force, which include medical students and students from other allied healthcare courses. It's through their input and passion that we're able to explore a variety of topics within the field, highlighting the vast potential that a career in academic primary care can offer. Tonight's topic, chosen by our students, focuses on a critical and often under-discussed issue in primary care, particularly the role of primary care in domestic abuse and violence. Our students highlighted this as an important area where healthcare professionals, particularly in primary care, are uniquely positioned to play a key role in identifying, supporting and protecting those affected. To help us navigate this, we are really delighted to welcome to tonight's speaker, Professor Jean Fader, who is a GP and a Professor of Primary Healthcare at the University of Bristol. His research interests began with health and healthcare of traveller gypsies and have since expanded to include chronic respiratory and cardiovascular conditions, as well as the health impact of domestic violence, with a focus on healthcare responses to domestic violence globally. He's chaired multiple NICE guideline development groups and led the WHO Intimate Partner Violence Guidelines. And in recognition of his outstanding contribution, Jean was awarded an OBE in 2017 for his services to healthcare and victims of domestic abuse. So without further ado, I'll now hand over to Professor Jean Fader. So throughout the session, please do use the Q&A box to submit your comments and questions, which I'll be posing to Jean at the end. Oh, you're just on mute, Jean, if you can unmute for us.
Thanks for inviting me to this. Can you hear me?
Yes, we can.
Oh, good. My microphone sometimes is not my best friend. Anyway, I'm just going to pull up the slides so we can start. I'm grateful to you for inviting me for this opportunity to do a bit of sort of looking back, I think, at some of my research work around domestic abuse. And I will now try and share my slides, that essential step when you're trying to give a webinar. Right, so far so good. What could go wrong? Right, is that visible?
Yes, thank you.
As a title slide, great. Okay, well again, thank you for this invitation. I just want to start with acknowledging that domestic abuse isn't an easy topic. You could say, well, there are many topics within medical education, within medical research that aren't easy, but this is particularly difficult because we may have been exposed to domestic abuse, or we may be in a family where there's been domestic abuse. We may be worried about our own behavior. So this can sometimes strike deep and it can be triggering. So that's a sort of so-called trigger warning. I don't really like the word trigger, but just to say that there is help around. So if some of what I'm saying, if you decide not to step out, which of course you are more than welcome to do, some of the support that's out there includes the National Domestic Abuse Helpline, which has a website, the Respect Men's Advice Line for men who are feeling victimized by domestic abuse, and then also the Respect phone line for people who are worried about their behavior. And I'm going to put these numbers up again at the end. They are quite efficient ways of engaging with support. I'm going to start with a patient, because a point I'd like to make from the get-go is that all my research within primary care has ultimately stemmed from my experience of patients and the kinds of questions that emerge from consultations with patients and uncertainty about the effectiveness of what I'm doing, whether it's prescribing, whether it's engaging in other ways, other types of interventions to support patients. And Constance, not her real name, was a patient I thought I knew really well. I'd known her for 5 years. And it was, of course, a Friday evening surgery, as it often is, when she was presenting with a vaginal discharge. And I asked her a couple of questions about the discharge, and then she said out of the blue that my partner has raped me. And then told me something about what life with this partner was like. I completely missed that she was in a very abusive relationship. When he got angry at her, he didn't hit her or push her or strangle her. He would stand by the fireplace where there's a samurai sword, and he would look at her and he would look at the sword, and she was terrified of him. And he was sexually violent to her. He raped her repeatedly. All this had been taking place during the 5 years that I knew her. And in many ways, it wasn't the only patient I had who disclosed abuse, but in many ways, this triggered for me a desire to really try and find a way to respond to those patients. And I looked at the evidence around how, as a clinician, as a doctor, and particularly within primary care, how we could respond safely and effectively. This was now almost 20 years ago, and actually it was 25 years ago. Time flies. There wasn't much evidence. And because I was already engaging in primary care research, I thought this was a question that I needed to try to address. How can we effectively respond to those patients who are experiencing domestic abuse, who have a history of domestic abuse? What do I mean when I'm talking about domestic abuse or domestic violence? Well, this is the UK government definition. I've highlighted that an important feature of this is that we are talking about people over the age of 16. So you will note that there is an overlap of 2 years between children and young people who are, if you like, under a safeguarding scope, and people who may be experiencing domestic abuse. And you'll also, I think, note that this is not just intimate partner violence. The UK definition focuses or includes other adult family members. So we're not just talking about abuse from a partner or from a spouse. The intimate partner violence definition, which I'm putting alongside it, I'm putting it alongside because it's the WHO definition, and also because it's done through the lens of the impact, the harm, the physical, psychological, and sexual harm of domestic abuse. And it also articulates different kinds of abuse. And it is a WHO definition. I want a moment's silence here because we've just learned that Donald Trump is withdrawing funding from the WHO, which is actually a global tragedy. We're not just talking about straight relationships, heterosexual relationships. We are talking also about men and women who have same-sex relationships. And we're also talking about specifically, because a lot of the evidence is going to be about violence against women, but we're also talking about domestic abuse experienced by men. It's a pandemic. the actual prevalence of domestic abuse. This is England, from the crime survey for England and Wales. By the way, I'm not putting the references. I know this is a quasi-academic webinar, but I'm not putting the references on. I'll give you my email at the end. If you want references to any of the studies that I'm citing, I'm very happy to send them to you. But anyway, the bottom line for lifetime exposure to abuse for women is 1 in 4 women, which is a large minority of the population. And for men, it's about 1 in 7, 1 in 8, depending on the metrics that you use. When it comes to sexual abuse within domestic abuse, it is much more common among women. We're talking about a lot of people, and we're talking about a lot of our patients. And this is not obviously UK specific. This is absolutely global, and it varies by region. But there is no region in the world where this isn't a major violation of human rights, which has substantial public health and clinical implications, which I'm going to talk about not in any great detail, because I'm aware that those of you who are medical students at George's already, if you're in the middle years, already have had some education around domestic abuse and partner violence. But I'm going to say something about it just to set the scene why I think this is such an important health and healthcare issue, public health and clinical issue. This is a sobering graph. The point of it is, and I'm going to explain it briefly. If you look at the left-hand points on it, which are studies, this is putting together studies around past year prevalence of intimate partner violence, not domestic abuse, specifically intimate partner violence, you'll see the population prevalence for the last year hovering somewhere between 5 and 10%. And this is women, by the way, that these studies were done. Quite old. We're now talking about a quarter of a century ago. When you look at the studies done in populations, in clinical populations, whether it's family planning clinics, whether it's gynae clinics, emergency departments, the past year prevalence is much higher. And if something that really made me focus on this issue was individual patients, it was these sort of data from studies which showed that the prevalence was even higher among the patients in my waiting room. And this was actually confirmed by our own study in 12 Hackney practices in East London, showing that the lifetime prevalence was with lifetime prevalence around 40% compared to 25% in women in the general population, and the past year prevalence was 17%. So I couldn't look at the waiting room in the same way ever again. And you'll see in a moment why that is the case, that in clinical populations, the prevalence is higher. And not just the lifetime prevalence, but if you like, current exposure to domestic abuse or intimate partner violence in the past year. I want to just acknowledge right now that, yes, men are also survivors of domestic abuse, and women are at greater risk. They're more likely to be injured, they're more likely to require health care, they're more likely to be in fear of their lives, and as I said before, more likely to suffer sexual violence. So this is a gendered problem, but it's gendered in many different kinds of ways, which we may have a chance to discuss a bit in the Q&A. And this is just some of the data on same-sex partner violence, similar prevalence and impact. If you look, this comes from the WHO multi-country study on the health impact of, I've called it domestic violence, actually it was intimate partner violence. It's that list of symptoms is remarkably similar to the kind of symptoms you get presented in general practice. Feeling generally unwell, non-specifically, some problems with mobility, some chronic pain, memory loss, suicidality, all of these are common presentations in general practice. And all of them, when you look at the odds ratio, the odds of having them and adjusting for how old you are, your marital status, education, all of them, the odds are greater if you've had a lifetime experience of intimate partner violence. The kinds of associations, and I'm going to say associations because there is some bidirectionality here, particularly when it comes to mental health. But these associations are repeated again and again in cross-sectional studies, which probably have a moratorium on doing these sort of cross-sectional studies. All of these kinds of symptoms and chronic conditions are more common if you have experienced domestic abuse in your lifetime. And again, this is more focused on women. Some of the data that's coming out from men is not that dissimilar, although less physical manifestations. And one of the most striking is that, your risk of having a cardiovascular event, an MI or a stroke, is increased if you've had the experience of abuse and violence in your life, particularly intimate partner violence. Once you adjust for every other risk factor, it's an independent risk for a cardiac or a cerebrovascular event. And not surprisingly, because of the ubiquity or the commonness of sexual abuse within domestic violence, it's the presentations of gynecological symptoms which is common. Now, I'm not saying it's the major cause. I'm just saying that it's an important risk factor, and it's usually hidden. It's hidden unless you ask about it. All of this is actually dwarfed by the mental health consequences. And again, I'm using consequences slightly carefully because with mental health problems and conditions, there's definite bidirectionality. You are more vulnerable to abuse if you already have depression or substance misuse, but it works both ways. And for very common conditions, depression, or for that matter, anxiety, your odds of having depression or anxiety is probably 2 to 3-fold what it is if you don't. And PTSD, which is a much less common condition, but often missed, I have to say, by us GPs, the odds of 7-fold odds, your odds of having are 7-fold increased if you've experienced domestic abuse. And unfortunately, this cascades down the generations. There's an intergenerational effect, and this has consequences throughout the life course of children. We now, because of the Domestic Abuse Act in the UK, do not consider that children are, if you like, we talk about them being exposed to domestic abuse. They are victims of domestic abuse as well, and they're recognized as such legally. This is hard. I mean, I just want to reflect again. And this is a magnification of hell. This is a triptych by Bosch, a Flemish painter, horrific painting. And I have to say that when there's a disclosure of violence or abuse in a consultation, or even looking at data around domestic violence and abuse, it goes beyond the data and it goes beyond words. There's something very horrible about being about the person who you expect, a family member, to love you most and look after you, for you to be afraid of them and for them to be hurting you. Okay, so now that's the sort of background, but I want to move pretty sharpish now to talking about some of my research, which basically all comes from general practice, and it comes in my identity as a primary care academic. Although, as I will say towards the end, we've now used some of those methods and looked at some other parts of the health sector. But there's a range of studies, and I'm going to talk about only a few of them. The big question, which faced me about a quarter of a century ago, was, what do we actually know about effective healthcare responses? And I've already alluded to the fact that we know very little. And at the turn of the century, I can say that certainly criminal justice, to some extent, social care was really ahead of health. We were the kind of missing, healthcare was the missing sector at the table, the metaphorical table around a community-based or societal response to domestic abuse. It had become, domestic abuse had become a public issue. The media was recognizing it, but somehow in healthcare, we were silent. And yet, my claim here is that particularly for general practice, because of our close relationship to the population and to social care, community health service, and secondary and tertiary care, we really needed to find a response, because at that time, when you were a survivor, you could go and get some support from the third sector, and UK is blessed with having quite a vigorous third sector, charitable voluntary sector response, where most of the expertise lies around supporting survivors. But you had to access it without much mediation from any of the other services that you were in connection with. And my goal was to try to do something specifically about that general practice domestic abuse support relationship. And then subsequently, I have done some work around secondary care as well. But that's what we were trying to do. In a way, simple. Well, simple in concept, challenging in actually designing a mechanism for doing that. Why us? I mean, for me, because that happened to be where I worked, it was in primary care, but I think we can make a pretty good case. And I think also this was alluded to in the introduction, that it's particularly the primary care response, because we have the most contact of any professional services, not just health services, with the whole population. And because we see, as I've explained, the morbidity that's associated with domestic abuse. And this, I love this graph, because it just shows that, the vast majority of the population, this is past year, attendance in general practice, slightly less in maybe teenage years, and slightly more as we get older. But we see the population. It's us. They're at our door in our waiting room. They're in our consulting room. So if we can't find a way of recognizing and responding to domestic abuse, how can we expect other, certainly parts of the health system, the NHS, to do that? I want to say something about evidence. And again, I think I'm preaching to the choir, because, the kind of education you're getting, those of you Georgia students or other medical students, you should know this, you do know this. I'm particularly interested in, and have devoted myself, I guess, to linking together studies around the epidemiology, the actual impact of domestic abuse, with systematic reviews and meta-analyses of what we know about interventions already. I don't think anyone should ever do a trial or an intervention study without first checking to make sure someone hasn't done it before. Systematic reviews are a good way of doing that. I'm particularly interested in randomized controlled trials, but they're not the only way to test effectiveness. They happen to be the most fashionable way, and one that has all kinds of philosophical reasons why you want to do that to reduce bias. But I'm also really interested in nested qualitative studies to understand trials, and I'm very interested in the economic analysis and cost effectiveness, because to get anything commissioned in this day and age within the NHS, or even globally, you're going to need to demonstrate cost effectiveness, or at least it's a great advantage if you can. And I'm very interested in the downstream articulation of guidelines and policy, because without that, why are we doing this research, frankly? So this is stuff I think. And there's all these quite interesting feedback loops, which I've experienced one way or the other over my research career. But what you may not know is that doing this kind of research without working together with survivors of trauma or abuse, I feel I think one's missing the possibility of really making research appropriate and answering real questions, and doing it in a way. I mean, we're moving towards an era of co-production with not just survivors of domestic abuse, but people with lived experience of a whole range of conditions, whether it's diabetes, HIV, psychosis, But so we've got to do that work together, I believe, with survivors, and we're also beginning to do work together with people who use abusive behaviors. So for me, the methodologies are all necessary, but they need to be linked together with people with lived experience. And so to start with that, what do survivors want from us, from doctors, from clinicians? And we actually did a systematic review, the first systematic review of qualitative studies in this field anyway. And this is what they want. And you might be able to predict this, but it's nice to have empirical evidence to show it. Before a survivor discloses to their doctor or their nurse, they would prefer that they would be able to see that person again, and it isn't a one-off, which is challenging for emergency physicians, by the way, easier for GPs, although we do have a problem with continuity as well. They want to be asked. Without being asked about abuse, it's very difficult to disclose it, as I discovered with Constance after knowing her for 5 years. When a survivor does disclose, this sense of not wanting to be pressurized to fully disclose. I mean, this is part of trauma-informed care anyway. If someone is disclosing trauma to you, you don't begin interrogating them about the details of what happened to them. It has to be, they have to remain in control of that. And it's certainly within this all can be cast in the context of trauma-informed care. The immediate response, the golden minute, is about acknowledging what has been said, respecting the fact that it's a difficult thing to say, addressing safety concerns. Is that golden minute? If in that first minute the doctor says, what did you do to make him do that? I mean, you'd think that I'm making that up, but actually in some of the early interviews we did in this area, that was what women were saying was sometimes a response from their doctor, a kind of questioning response that means it'll be very difficult for that patient to disclose to anyone, certainly to any doctor again. And something about chronicity, which again, coming back to primary care, we know about chronicity. We deal with chronicity all the time in our consultations and in our practice. And that sense of the chronicity of a problem, I think GPs bring to this issue. It's part of our expertise. Anyway, that's the systematic review. Still one of the most cited things I've ever done, one of the most cited publications I've ever produced. Reviews, systematic reviews, mission critical. And I'm glad to say that now within this field, there are pretty robust Cochrane reviews. And that is a strong evidence base for trying to figure out what is best practice and what needs to be commissioned. We also have evidence-based guidelines, and they both come from the WHO and from NICE. This is the problem. They're now 10 years old. We just managed to convince NICE and in fact the WHO to update them and revise them. But they're the kind of the cornerstone of putting together what works and also where there's uncertainty. This field, the field of domestic abuse, has these guidelines now. I want to just touch on an early challenge that came when I began doing research in this field, because 20 years ago or so, there was this view, not particularly from healthcare, but from activists actually, and from other sectors, that we should be screening for domestic abuse in all settings, and particularly in healthcare settings, almost as a symbol of it being a way of showing that you care. And also there were some arguments that it also makes it more possible to talk about it if you ask all patients about abuse. And we looked at the evidence around this, first for the HTA, and then we did a Cochrane review. And it turns out that there isn't evidence for screening. And there still isn't, even though some guidelines, the US guidelines do suggest it. And it turns out it was the biggest red herring that was there in the beginning of my work around domestic abuse was people used to challenge me saying, but hang on, if doctors don't do screening, how are they going to know that a patient is experiencing abuse and da da da. It was really it was quite interesting, the sort of that sense of different cultures and even politically being in a bit of a struggle about that. I think that's over now, and I think there's a recognition that the most important thing isn't how you identify, but actually what the response is after that. But it's interesting that I thought the science would put it all to rest, and actually it needed more than just the science. But I thought that was just an interesting little anecdote from the history of domestic abuse research. I want to now summarize briefly the evidence we have for effectiveness, because I'm going to go on to talk about some specific studies about engaging primary care. And there's no point in doing it unless there's some evidence of effectiveness for what other doctors or people they refer to can do next. So the first area of evidence is around domestic abuse support workers or advocates, most of them working still within the third sector, within the voluntary sector. And basically there is reasonable evidence, that's why I've got the ish, that what they do and what the sector does is effective. And as I say, that now has the evidence of a Cochrane review behind it. They're the crucial partners. And whatever we do in the health system, we have to partner with domestic abuse expertise, either advocacy or support workers. And some of that is also taking place within healthcare. Mostly it's within the third sector, but there's real uncertainty about the benefit of advocacy for psychological outcomes, the sort of once you go beyond immediate safety. There's good news on psychological therapies if they're trauma-informed. They are effective for some, not all outcomes, most effective for depression, anxiety, less robust evidence around PTSD. Again, there is a Cochrane review that really nails that. So, we don't use medical students as doctors. You don't want to go sailing into kind of a practice where you don't think there's evidence for effectiveness. There certainly is evidence here for effectiveness if the patients get the benefit of advocacy and the benefit of psychological trauma-informed psychological therapies. How do they get it? How are they recognized? So that was the question that led to my research around what to do in primary care. And the goal was a modest one. It was this goal, domestic violence aware practice. We weren't saying, hey, general practice, you're going to become the experts around domestic abuse any more than I guess you become the experts around psychosis or diabetes. You have an important role, but you need to be aware of domestic violence as something that your patients are experiencing. So very much, if you like, building on the epidemiology. This still is the model for IRIS, which is the intervention. There are a number of factors that went into it: training and support, referral pathways, prompts in the medical record, the electronic medical record, linked to an advocate educator, and having a practice champion. The outcome of the trial that we were measuring was not the most important outcome of interest: abuse, quality of life, mental health, and safety. It was identification and referral. So we were making the case, which thankfully the funders and the journals accepted, that if you can show an intervention improved identification and referral into the domestic abuse sector, you will benefit patients. So we needed the Cochrane review actually to make that case, because otherwise they would have said, hang on, how do you know you're really making a difference when you're developing and evaluating the intervention? But we felt we had the evidence to do that. This is what the trial looked like, concept diagram that some of you may recognize. We were randomizing by practice, not by patient, but by practice. The power is driven by the number of practices that we had. And, there was some practices did decline. So external validity, you can argue, but the majority of practices were willing to join the trial, and we hung on to all of them, and we were able to look at the identification and referral data. Now, this box and whisker plot does that. It shows the blue is referrals, the pink is identifications. And the first thing to notice is that if we hadn't done a trial, we'd have assumed that all the identifications were as a result of the intervention. It wasn't, because the control practices did also identify some patients who were experiencing abuse. They weren't referring them, but they were identifying them. And the other thing to notice is in terms of the proportion of the practice population, we were only identifying 1.5% at best in some of the practices. And when you think of what I said about even the last year prevalence of 17%, we were still only able to identify the minority of patients who either were not willing to disclose or weren't being asked about abuse. We did find clear cost savings, both NHS and societal, when we modeled this. And that was for us as important as the main trial result, which I won't linger on anymore. But that for me, in terms of the evidence base, was as compelling, and as compelling, obviously, to commissioners as the actual effect size, which was substantial. What happened next is, I guess, the part I'm most proud of here, that, we did not stop at saying, hey, we've got a great trial. We published it in the Lancet. We've got lots of other publications. And no, we really felt we had to go beyond that. So we worked quite hard. And this is something now the National Institute of Health Research, a major funder, actually gives you funding for, to increase the impact of your findings. At the time, now talking 2009, 2010, 11, we didn't have that sort of funding, but somehow we still did manage to get this out into the world, into policy documents, and we worked together with the Health Foundation, and we got it into a number of government outputs as well, or government publications and guidance. And it was really making the most. And this is for you as future researchers, some of you be future researchers, best to choose research topics that you really believe in and I think are important, because you're going to need a lot of energy, not just to do the research well, but to also get your findings out into the world. A big question, though, is, hey, this worked in trial, but what about in real life? Can it actually work? So we were funded then to do further work looking at its implementation in Northeast London. Not a trial, it was another design, an interrupted time series, also trying to reduce bias. And the results were, well, I would say this graph almost speaks for itself, looking at referrals. An interrupted time series allows you to mark when the intervention started, which is that dotted line, and you can see the effect it had. You can also see the dotted line there is equal in time in a borough that didn't have the iris intervention, just to make sure we weren't just getting a secular trend here. Well, nothing was happening in a sister borough at that time. So I think we had pretty strong evidence that this could work outside of a trial design or outside of the precious, context of a trial. So the answer to that is yes. I don't know why the text has gone white here, but we've also managed to show this can work outside of general practice, but in another part of primary care, which is sexual health services, primary care being a healthcare setting you get direct access to. And we showed it was feasible, acceptable, and we also saw the increase in referral. So it has legs. This intervention has legs. It needs to be modified for different healthcare settings, but it can work outside of primary care. The final step of the IRIS story is that we were able to use that evidence as the basis for a social enterprise called IRIS-I, which has been responsible for national upscaling of the intervention, of the program really. And as a result, it's now been commissioned in 40 different sites up and down the country, 40 ICBs or local authorities, and getting on to now nearer to 40,000 patients who've been referred within the system. So actually, it exists out there. Unfortunately, it, as I'm going to say in a moment, it is threatened by the very austere economic environment that we're in at the moment. So the commissioning of this, despite the evidence base, is by no means guaranteed. But I just thought I'd show you a few, and this comes from the IRIS-I portfolio, some of the data we have from patients who have benefited from IRIS. I'm forever indebted to my GP for piecing it all together, for getting me that help. As a GP, that's the kind of feedback that obviously I really like to hear. The statement is like an extension of my general practice of my GP. That was certainly our intention. So patients do appreciate this, but so do clinicians in general practice. And by clinicians, I also mean nurses. So a real sense that it makes it possible to ask, it makes it possible to address what's a really difficult problem, one of the most challenging parts of general practice. I'm moving towards the end now because I do think it'd be nice to have some Q&A. Also, my dog is whining, so please forgive me because I'm going to put him out of the room. Whining and preparing with the webinar. Right. Apologies about that. Okay, but I want to, by way of trying to conclude, I just want to point to a couple of other studies. I'm not going to give you the details. You've probably had more than enough detail already. I mentioned that there's this big evidence gap around, not big, there's an evidence gap around the psychological support that survivors need. Works quite well for anxiety and depression, perhaps doesn't work so quite well for PTSD, and the effect sizes in the trials aren't that impressive. They're probably past the minimally important clinical difference, but still challenging. So we did a trial where we combined advocacy with psychological support. So we trained advocates, domestic abuse support workers, in psychological methods, trauma-informed methods, and we individually randomized people to who were seeking help from the domestic abuse sector to either just getting advocacy or getting advocacy plus psychological support. And we were able to show that you could increase the benefit by combining the two. This has not been commissioned yet up and down the country, I'm sorry to say, despite some efforts on our part, but it shows that it's possible to bring these two expertises together, and of course the two sectors together. And then the big challenge, of course, is if all your efforts go into supporting survivors, which is absolutely right, though, that you do support them, what about the people who use abusive behavior? And it's a bit, like that public health metaphor or image, rescuing people, scooping them out of the river at the bottom of a valley, when they've fallen at the top. What about stopping them from falling in? What about stopping abusive behavior? So we've just completed an individually randomized trial through COVID and through thick and thin, 5 years, lots of T-shirts and scars around that. Which I can't actually give you the result of in any detail because we haven't yet published it and it hasn't even got into the public domain. But just to say, it's a question that we really were concerned about, and we are able to address or contribute to the evidence base around the effectiveness of working with people who use abusive behavior in a group format. So it's, to me, this is just as important as actually working with survivors. And then the final thing I just want to point to is that we've worked together with colleagues in Brazil, Nepal, Sri Lanka, and the occupied Palestinian territories around morphing the IRIS response into a shape that's appropriate for their primary care services and their reproductive and child health services in order to try to improve the healthcare response in those countries. And we've just completed a global, NIHR Global Health Group program, a 4-year program, it turned out. Again, because of COVID, it was extended. And we've, you could say this was the conclusion. Did we really need 4 years and a couple of million quid to do this? Well, we kind of did. What we showed in quite a lot of detail, and again, if you want, I can send you this policy briefing or send you the papers, that you really needed to take into account the local context, not just of the services, but obviously of the culture, the surrounding social system, in order to have an appropriate response to domestic abuse in different countries. Kind of obvious, but what we did is we showed that it could be done. You could take context into account and make services that were feasible and acceptable. We didn't do trials, we did pilots. So that's been quite important learning for us, that, you know, there are no shortcuts in doing that. So this is a slide from the IRIS-I portfolio again. You know, there are big challenges out there, and I'm going to read some of them. Well, I guess I'll read all of them. Really. Clinicians don't want to invest time if the program isn't sustainable. They don't want to engage. We need longer commissioning cycles. Yes, please. It's unfair to set up something that disappears. What happens to patients? Now, this is a big critique of pilots and even of trials if afterwards you aren't able to embed that. The sense of like who pays, this incessant argument between ICBs and local authorities, who should pay for this? Is it healthcare? Is it social care? Is it, frankly, guys, you know, you need integrated commissioning around this, and that isn't happening yet. And interventions are more than training. The training alone will never work. You need that referral pathway and you need the reinforcement. And this has to have leadership from the top. And at the moment, the leadership around the domestic abuse response, I would say, to be diplomatic, is patchy. There is this, this is like a cartoon, I'm sorry, but this image does a lot of work, because there is demand. There's demand from survivors. There's actually demand from people who use abusive behavior. There's demand from academics producing evidence. But the actual capacity within local authority, healthcare, and third sector is insufficient, and is likely, unfortunately, over the next couple of years to be less sufficient. So there's decommissioning of say, of IRIS services in different parts of the country now, despite it having such a strong evidence base. So we're in a tough time, and we really need to work with the new government to say, if you're serious about reducing violence against women and girls by 50%, that's their aim, you're going to have the resources within healthcare as well. I mean, this is my fantasy of what health can do through collaboration with the other sectors. And when I say fantasies, some of this is already happening. In quarter of a century, there's really been progress around this, but we really do have a long, long way to go. I've got the privilege at the moment of being director of a UK PRP, violence prevention consortium of 9 different universities, where we're working around integrating data and integrating the kind of responses you can get between the different sectors. Because I think that really is where we have to get out of the silos. So this is health's problem, this is the sector's problem, this is local authority problem, this is a societal problem, and we need to work together in an integrated way. We really need to improve the evidence base around children and young people, and we're doing some of that work within Vision as well, around adolescent domestic abuse. And if you're a child or a young person, an adolescent, there may be abuse in your relationship with your girlfriend or boyfriend, but you may also be in a family where there's where there's domestic abuse, it's complex, and we need to think how to support children and young people. We do need more research around male victims. It's still under-researched, and we do need more research around how to work with people who use abuse, and we're doing some of that work now. That's my email address if you want some more information. That's my research group in Bristol. I'm going to end on something. I know I said I would end quickly, and I've taken a bit longer. If you, as a future clinician, a future doctor, have experienced domestic violence or been exposed to domestic violence or abuse as a child, it will be more difficult to work with patients who are experiencing abuse or have experienced abuse. And we need that to be part of medical education as well. It's not the only thing. I mean, if you have a parent who's died of, I don't know, ovarian carcinoma, and then you're being trained around in gynecology around ovarian carcinoma, that is also difficult. But there's something specifically problematic if you've had your own trauma. And sadly, when we look at the experience of domestic abuse of healthcare professionals, I defy you to guess what the proportion is from this meta-analysis. It's as high as the proportion within clinical populations, like in the general practice study we did. It's substantially higher than in the general population. And this is us. I mean, I'm talking about us, us, those of you who are medical students or doctors, So I think we have to take that into account in how we do our training. And just I want to end then with those contact details. If this has been difficult for you as well to hear, then these are sources of support.
Thank you, Jean, for walking us through a really difficult topic with so much insight and sensitivity. It sparked quite a few questions, so I'm keen to bring them forth. If you could stop sharing the screen, that would be great, Jean. So our first question: what have you learned about influencing policy through this work?
What I've learned is that it's hard work, and that you have to develop a kind of competence and expertise as well, because it's a different competence and expertise. I've learned that you need to collaborate with the other stakeholders who really want this to happen. So that the effect, to the extent that I've had any effect on policy, it's been in kind of partnership with other stakeholders and really just listening carefully. It's also, frankly, about making friends with and having a relationship with politicians and civil servants, who want to do the good. But it does require effort and resource. I guess that is the bottom line.
Thank you. A couple of questions from students saying, do you have any advice for students on how to ask patients about potential domestic violence, especially when children are involved, which makes the parents more anxious?
Yeah, the short answer, which is like me ducking the question, is that you do need training on that. And certainly within Bristol, we make that as part of communication skills, how to ask. But I think the more general answer is you have to ask in a way that feels comfortable for you as well, because we all have different ways of consulting and asking questions about difficult things. So part of that is rehearsing that. When it comes to children, and then of course you've got, and you're quite right, you've got the shadow of safeguarding and the fear that parents, survivors have, that if they disclose, that they may actually lose their children. I mean, that's extreme, but it's certainly in people's consciousness. And so I think there's training as well about how to respectfully, ask if you're afraid of someone at home, or whether there's someone at home who is hurting you. These are the kind of questions that one can ask. But in asking or in responding, to say very clearly that what you tell me is absolutely confidential, except if I am concerned about the safety of your children, then I would want to talk with you about some further support for that. And I might have to actually tell a third party or an expert, or however you want to phrase that. So I think one has to be honest. Um, obviously the vast majority of survivors want the best for their children. So it's not. My own experience is that there isn't the kind of conflict that we all worry about. It's been very rare, even though I ask about domestic abuse a lot, that there is a hesitation to ask for that reason, and a hesitation to disclose for that reason. But it requires training, and obviously I hope George's, or whatever profession, whatever part of the profession you want to go into, has that kind of training as part of their curriculum.
Thank you, Jean. Another question from a student, quite apologizes for a few questions, but you touched on Trump's withdrawal of funding to the WHO, perhaps the start of many disappointments. Is research into domestic violence underfunded, under-recognised, and what are the research priorities? Any advice for students who are interested in getting involved?
So yeah, the WHO, which is of course not a research organization, it coordinates health prevention and better clinical practice around the world. I think, the good news, so I can leave you with some good news here on that question, because in the UK, there has been a concerted effort, particularly on the part of the National Institute of Health Research, to fund research around domestic abuse and safeguarding more generally as well. And that's only been in the last decade or so. The MRC as well has funded. So it's the original work we did in Palestine and in Brazil came from the MRC, Global Challenges. So I don't know whether this is going to continue, but at the moment, domestic abuse research is being funded. And I think it may be slightly more difficult to get epidemiological research funded, easier to get kind of downstream trials. But it's a good time. And for student, what I would do as a student, if I was interested in this, I would find an academic who was applying for a grant or was in the field and who'd be willing to support a student project within that. So I think, the way into research for medical students tends to be a bit of serendipity. In Bristol, we have something called student choice projects, where students can choose to hitch themselves to a research project and get some experience in data management or data entry or even writing. But I think we're in a, touch wood, we're in a better space around research funding for domestic abuse now than we were when I came into this field, when in fact the field it didn't exist.
Thank you. Another one from a student who says the two of the main and consistent places I've seen screening for domestic violence being encouraged is the postnatal GP check and in A&E. Do we know if these are effective?
No, they aren't. We have evidence. When I say they're not effective, what we don't know is it's more effective than what you could call clinical inquiry or clinical curiosity or selective inquiry. I'm not saying it's less effective. So, and I will, if the student is interested, happy to send an article that I wrote a few years ago saying, let's stop arguing about this. It's a bit like the red herring issue. If a service wants to do screening and it trains the clinicians to do it well, not just like in maternity care, like antenatal care. Most of my colleagues, not surprisingly, are women. Most of them have gone through antenatal care in the time I've been working with them. And all of them have come back from their booking appointment going, I can't believe the way they asked me about domestic abuse. Everything's all right at home, isn't it? Tick. Nothing bad. Unless you train midwives or emergency nurses, doctors, physicians, or child health doctors or health visitors in how to ask as if they want to know the answer, it's both a waste of time and possibly dangerous. Certainly a waste of time. So there's no evidence is better than selective inquiry or clinical inquiry, but whatever you do, it needs to be done in the context of good training and having a referral pathway. Because if you have to hold a disclosure yourself as a frontline clinician, you're going to be quite inhibited about asking, because it's holding something. It's like a moral injury. It's holding something quite difficult. So I hope that the emergency department you've worked in child health clinic has a referral pathway for when a patient does disclose.
Thank you. And I think we've got time for one more. So, comment from Sarah. In a time of financial austerity, society, adults, large organisations push for their part of the pie, and cuts come from children's care, including health visiting, education. I put to you that it is time to consider prevention as so much more effective than treatment and follow up. Would you give up funding for children?
I'm an and person, not an or person. So I accept the premise of your question, but we've got to do the and. And if a society forces us into those kind of decisions, I will always fight back and push back. I do think we need to look at both prevention and mitigation and care for survivors. It has to be and. So, but I do accept the premise of the question. It's just that I would always come back with an and, not an or.
Thank you, Jean. It's been incredibly inspiring hearing your journey. I've just got a few more messages for the rest of the team. I'll just share my screen for one final time. So we look forward to seeing you again on the 4th of February, where we'll be joined by Heidi Phillips, Associate Professor for Primary Care at Swansea, for her rescheduled session on neurodiversity uncovered. All the seminars will be available online if you're unable to join us live. And please, we do welcome your feedback as we continue to develop this series. So please do use the QR code or a link will be sent to you following this session. Thank you all for joining us and good evening.